Welcome to Passive Curiosity in an AI world where we explore tomorrow's careers through the lens of AI. By the time that sepsis is obvious, it can already be too late. Dr. Gabriel Wardi is using AI to detect hidden dangers earlier, turning life-threatening emergencies into life-saving moments. Today we're continuing our AI in Healthcare mini-series, and I'm excited to be joined by Dr. Gabriel Wardi. Dr. Gabriel Wardi is an emergency and critical care physician at UC San Diego Health, where he is an associate professor and the founding chief of the Division of Critical Care within the Department of Emergency Medicine. He completed his emergency medicine training at UC San Diego, serving as chief resident, and went on to complete the institution's first joint fellowship in critical care medicine. His research focuses on sepsis, resuscitation, and the interface between the emergency department and intensive care units, with an emphasis on using machine learning to improve patient-centered outcomes. He led the clinical implementation of a deep learning sepsis prediction model at UC San Diego Health that reduced sepsis-related mortality by 17%. Dr. Wardi, thank you so much for joining us today.
Of course. Well, thank you for the invitation.
Yeah, so to start off, if your student self followed you around for a week, what would they see you doing and what might surprise them the most?
Oh, yikes. So I think, the way that my career is set up right now is there's a lot of things that I kind of juggle. There's clinical time in the emergency department, there's clinical time in the ICU. There's a pretty heavy component of research that focuses both on clinical trials as well as some more retrospective investigations. And there's also some administration. So, like most people at an academic medical center, I wear quite a few hats. And on top of that, I have three young children at home that always keep me on my toes throughout the day. So I think probably one thing that if I was a student following myself around, I'd say, wow. On the clinical side, I think what I would probably comment on is the emergency department is really busy. It's really fast. And there's a chaos to it that sometimes makes sense, but only after people see it for quite some time. If I were to walk in the ICU, I'd be like, there's a lot of cool machines right now. And oh my gosh, I didn't know about some of the technology that's made its way into medicine right now. And if I were to see some of the research that I'm doing right now, I might actually feel the most comfortable with that because when I was a student back in college, I was a biomedical engineer and did a lot of signal processing. So at least that makes a lot of sense to me about the ins and outs about how that works. And the administration and leadership side, I'd probably think is incredibly boring. And why would anyone spend their time doing this?
I appreciate you taking the time out of your very busy schedule to do this podcast. So I wonder what first pulled you towards emergency medicine, and when did data or AI start showing up in your work?
I got interested in medicine when I was probably a sophomore in college. I wasn't one of these people that when they were 5 years old, they knew they wanted to be a doctor and their entire life's quest was to kind of achieve that goal. And like I said, I was a biomedical engineer. I was at Georgia Tech, great undergraduate school. But I felt that engineering really wasn't my calling. And I was working in a lab with someone and they said, you should maybe take a look at medicine. See if it's something that fits your talents better. And the reason I got into emergency medicine is that was the first place I volunteered was a local hospital in Atlanta. Um, People there were extremely kind. I was, one of the little volunteers giving people blankets, fielding questions and things like that. But that kind of set in my mind what medicine was. And I kind of continued, and throughout medical school, there was all kinds of things. I got tons of exposure to things like surgery, pediatrics, neurology, psychiatry. But to me, medicine always meant that, kind of that busyness and that hustle of the emergency department. And I think that's what kind of pushed me down that pathway.
So, building on to what you're saying, how did working in the emergency department change the way you think about problems beyond individual patients as well?
Yeah, I think the emergency department is in some ways a litmus test of what's going on in the community. And I think that's one of the things that I really enjoy about emergency medicine is, we'll take care of anyone at any time, regardless of their ability to pay. And I think there's a very strong component of, for people that are in emergency medicine that almost, that social justice, right? That we take care of everyone. And so, you have a good sense of kind of what's going on in your community. And you start to say, hey, maybe there's ways that we can keep people out of the emergency department by getting them taken care of in an alternative strategy. Or if we get them in our emergency department, how can we make sure they get very efficient, very meaningful care, seeing kind of what we're dealing with. And I think that's been kind of it's been a guiding light for me throughout my career in medicine, is kind of seeing what's come in. And that's how I got interested in sepsis. Just a few background stats for those of you listening who don't know what sepsis is, but probably the simplest way to describe it is if the body has an infection, the response of the body to that infection causes damage to the internal organs, things like the heart, the lungs, the kidneys. And it's more common than people think. It's estimated there's about 1.7 million cases a year in the United States. And of that, about 350,000 people die. So you can see in a country like the United States, that's a big public health interest to see how we can take care of patients with sepsis. And then if you take a step back and you think about internationally, there's about 50 million cases a year worldwide. And of those, about 10 million people die. So it's a huge, huge issue. And it hasn't gotten the same recognition that something like, let's say, a heart attack or a stroke, where if you don't know much of anything about medicine, you know that if someone's saying they're having a heart attack, they're probably clutching their chest with chest pain, right? And if you hear someone's having a stroke, you're like, oh, they're probably not moving their arm or their leg, or they're having difficulty speaking. But if someone says they might have sepsis, a lot of times in the general public, they're like, ooh, what is that? And even amongst healthcare workers, there's tremendous variability in what people think about what sepsis is. And it can oftentimes be a very, very sneaky diagnosis that comes through. And so that's how I got interested in the AI side, is coming up with ways that we could use data to identify these patients in the emergency department to see how we could catch them before their sepsis became very, very severe and led to have them end up in the ICU, where I spend a good amount of my clinical time.
Yeah, you don't hear about sepsis that often. You mentioned how AI can maybe help this huge problem. In a fast moving emergency department, where can AI genuinely help clinicians today?
Yeah. Well, I think, AI, like anything in medicine, is a tool, right? You have to have a clear problem and see how the tool can fix it. Because there's an old saying for a biomarker that we use to investigate that a fool with a tool is still a fool, right? So you want to put something out there that people are excited about, that can improve something. And if you think about how emergency departments work, you take a huge net of people that come in, and we try to rapidly determine where they need to go. And that flow is the magic word of emergency medicine. So anything that can help with flow is going to be an automatic plus. How can the job be done faster and just as safe? Scores you huge bonus points. And then you also want to make sure that you're getting the appropriate diagnosis. Diagnostic uncertainty is a big problem in medicine, and obviously for cases that are very clear cut, it's not a problem there. But a lot of times, patients come in with somewhat vague symptoms. And for time-sensitive conditions like sepsis, or let's say stroke or heart attacks, the sooner it's identified, the sooner the appropriate treatment can start, and that minimizes the damage that patients experience. Heart attacks and stroke we do great with, right? Misses for those exceedingly, exceedingly small don't happen much. But we know time and time again that sepsis continues to sneak through. I'll give you two examples right now of how, AI can be used very elegantly in emergency medicine. The first is through the early detection of sepsis. And that's what we did at UCSD, is that we put out a machine learning model that fed in patient data, demographics like how old they are, gender, what medical problems they have, vital signs that they were coming through that were put into our electronic health record, the lab results that were coming back. And what we are able to do is give the providers a 4 to 6 hour lead time of when the model thought someone was going to develop sepsis, that would then let them start the therapies we know that improve outcomes. And that's why we got really, really excited, because like most things in medicine right now, there's a ton of interest in AI. Everyone talks about how great AI is in medicine, but only a handful of folks have actually taken an AI application and said, we put this into clinical practice and it actually changed something. And that's what we were able to do. And like you mentioned earlier, when we went live with our AI model, what we found is that after we went there, we had about a 17% relative reduction in sepsis mortality. Now, to put that in terms of lives saved, that's about 5 lives a month that come through the emergency department at UCSD between both our EDs. And that, to me, is very, very significant because that's 5 people that have made it out of the hospital, whereas before this, for whatever reason, they would pass away in the hospital or shortly around that time. So that's one example. And again, that's what I put a lot of work in. And we can talk about some more applications and some of the spin-offs and ways that we can use it. I think the other thing that we're seeing a lot of interest in emergency medicine right now comes with efficiency. And remember, emergency departments are busy places. There are pressures to see lots and lots of patients in a somewhat short time period. And I think one thing that almost, and I will say almost, and I'm going to say everyone, I will say every emergency department provider hates writing notes. And the more time you spend writing notes means more time you spend in the hospital, more time you're away from your family, and it's just frustrating. And I think one of the great advances that we've seen very, very recently are these ambient AI tools that can listen to a patient encounter and then have an intelligent note that is then put into the electronic health record that the provider can then review for your accuracy and use that to kind of document. And I think, to me, that's something that's very, very exciting. All my friends that have done it love it. And it lets you get back to a lot of why you went into medicine, to sit down with patients, not rushing around as much. And from what I've seen, at least, these notes are really good. They fix all the things that I am guilty of, like forgetting to put something in there, typos that are ubiquitous through every note that I write because I try to go fast. So I think for me, that's a wonderful application of artificial intelligence because, again, there's a clear problem and there's a clear solution that can be used with the AI as a tool that is helping us achieve that goal. So that's how I think about it. And again, I think it's a wonderful way to kind of build up what you're doing.
Yeah, 5 lives a month. That's incredible. However, of course, there are places that AI could fall short. So, where do you think AI is least helpful or even risky in emergency care?
Yikes. So yeah, I think that's a wonderful question, right? And again, it goes back to what's the application that we're using it. And I think where I see people get in trouble, and it's not just with AI, but it's with really any kind of clinical decision support, that people fail to realize that it's a tool, it's not perfect. And blindly following a tool that says, hey, do this, outside of that clinical context can get you in a lot of trouble. So using sepsis as an example, right? At UCSD, we have this wonderful sepsis predictive model, but it's not perfect, right? It's going to flag some patients that are not septic, nor will they be septic during their hospitalization. If the provider blindly follows that and says, okay, the tool says it could be sepsis, I'm going to start down some therapies that the patient doesn't need. That's a pretty clear example to me of, again, the provider not using the AI application as a tool, but rather as a mandate about what to do. And I think that can get us in a lot of trouble. I think other things that I think are very fair to point out is a lot of medicine is clinical reasoning. And it kind of goes back to, what I was just talking about. But if you fail to maintain your clinical reasoning skills because you're reliant on an AI approach to diagnosis or treatment, you get yourself in a lot of trouble. Effectively, right? You're taking a step back and you're no longer a physician that's been trained to use probability of what's going on, diagnostic reasoning, and you're taking a step back and you're avoiding doing that. And I think that's probably more of an issue with the younger generation that's in medical school right now, is to kind of rely on that heavily when they're developing clinical reasoning to fall back on something else that's making the decisions for them. Very similarly, right? You could say, hey, ChatGPT, write me a paper, right? Or do my homework, right? And you're losing even though you might get a perfect score or near perfect score, right? You're losing that ability to develop your brain to maintain that. So I think that's something that certainly can get us in trouble. Other things, there is always a medical legal risk of using these tools. And this is a big, big domain right now of, kind of what does that look like? I know there have been some surrounding institutions in San Diego that have had big lawsuits filed because patients say, hey, I wasn't aware that AI was going to be used. I did not give consent for this to happen. And that creates huge issues for health systems, particularly those that are starting to incorporate AI tools into routine clinical care. So there certainly are risks. There certainly are, many examples of times where it can get you in trouble. But again, I think as the path starts to move forward with very intelligent use, that it certainly can improve outcomes for patients, get back to, helping physicians be physicians and kind of leave away some of the routine documentation and things like that that really drive people nuts.
So, what you mentioned flows into my next question perfectly. In high stakes moments, how should clinicians use AI without leaning on it too much?
Yeah. I think, it depends on the situation, right? So I'll give you a few examples, right? So let's say that there's a person that shows up to the emergency department. They're in cardiac arrest, right? They're getting chest compressions that are going on. It's an extremely hectic environment. I don't think there's much of a role for AI during that initial resuscitation, right? When someone is doing life-saving procedures at the bedside, right? Very, very, high stakes, very, very time sensitive, just because we don't have time to get that back. All right. But where I do think there's a role is again for, things that might not be that critical, that we can then kind of use it to kind of push people in the right direction early on in the care. And I think, again, sepsis is a clear-cut example. There's examples, too, of using this in the interpretation of the EKGs that we get for patients to kind of help improve how providers interpret these. I think that's a very, very good use right there. That again, it's a symbiotic relationship that it's building, it's 1+1 is not 2, but 1+1 is 3. And again, it's interpreting it within the appropriate clinical context. It's recognizing that the tools are not perfect, much like physicians are not perfect, but together, there's going to be that added benefit of making sure that either nothing gets missed, that an esoteric diagnosis is not overlooked, or that there's some improvement in the efficiency that's going on for someone in the emergency department. And again, I think smart tools, right, that are built certainly are going to be very, very helpful. But there always are going to be those that are kind of put out there that just don't really click, right? If the provider doesn't want to use it, if it's a laborious procedure to kind of go through, and if it's not adding value and improving what's going on for the patient, then you got to sit back and be like, okay, not really. It's not something that's going to get incorporated widespread. So hopefully that answers your question. I know it's a little bit long-winded, but
Yeah, so expanding a little, what separates the alerts that clinicians would trust from these AI models from the ones that they would ignore?
I think one thing that's critical is if physicians work in the development and the validation of the AI models. And I think that's something we've worked with at UCSD quite heavily, is that if we're going to build something, it's not just engineers in a black box that are saying, hey, do this, right? Providers are working with them. This works for me. This doesn't work for me. I think this is a great idea. Other things that I think become quite useful with this is there's an entire field called implementation science where taking an idea, making sure that people actually use it. This is not just an AI, but rather this is something that is across, for any number of therapies in medicine, right? You have a therapy that makes an answer that improves outcomes, but people choose not to use it. You can think of any number of medications, any number of therapies that people are given and they don't use it. So why is that, right? That study of how to get people to use it, I think, adds a lot of value into getting AI tools that actually people like to use. They even might get excited, and at least there's an understanding of kind of where it kind of goes out.
Yeah, so you've worked with implementing one of these models. What might tend to break when an AI model moves into the real emergency department?
Ooh, that is a great question. So in terms of what kind of things that can break, Um, I think there's obviously going to be the initial pushback from certain providers. And in my experience, usually these providers are going to be the older ones that have been around for longer, right? That are maybe not as tech savvy. Maybe they trust their clinical judgment and they don't quite see the benefit. That can be something that maybe not break per se, but certainly there is significant barriers that come with that. Um, Other things, there is always going to be that odd kind of interaction sometimes between, again, people that like an AI tool and people that don't. And that's something that's it's a very interesting phenomenon to kind of watch how people, approach this about what they take from it and what they don't. There are financial concerns. Obviously, AI is not cheap. Large language models in particular have a tremendous energy footprint. So in terms of things that break, so to speak, certainly the piggy bank is something to be worried about with some kind of damage there. So that's, I think that is a fair concern with it. And there's sometimes, honestly, depending on the situation, there can be the patient physician interactions and connection that if the AI tool is not, seamlessly integrated, certainly can create some friction there. Either that patients really want some kind of AI approach to what's going on, and things like, it's not needed, or vice versa, that if you were told that, well, the AI model thinks that this is going on, but I'm not quite sure about it, right? There can almost be a shattering of that patient-physician relationship that's going on. So again, it all depends on the situation about what's going on, about kind of what can get in trouble. Obviously, with dependence too, like we talked about earlier, right? The thought process in medicine certainly can be impacted by what's going on. But again, I think the hope is that with intelligent implementation and well thought out uses of AI, that everyone's happy with it.
Yeah, so once you take this tool and it's implemented, how would you know if it's actually improving the care versus just adding to the complexity?
Yeah. So I think that, with most health systems right now, there's a push to measure, right? You want to measure patient outcomes. You want to measure your throughput. You want to measure, how, for a specific diagnosis, how people do. And it's no different with any AI application, right? If there's an intervention that we do, we want to measure it and see what's going on, what are the key outcomes that we're seeking to change, and how that's impacting it. Now, this gets tricky because oftentimes, if it's just a simple before and after, you can imagine that if you put a tool into place and everyone starts staring at it and says, we're going to start focusing so heavily on sepsis. Here's a new tool, but we're going to watch everything you do. You can probably imagine it might not be the tool that's actually doing it, but rather what we call the Hawthorne effect, that the close observation is actually what's driving the outcomes. So measurement is key, and the more sophisticated the tools that can really kind of get to see, is there a causal impact, meaning that the intervention in place is actually doing the desired effect, and there's not a confounder that's also kind of driving what's going on. And again, that can be a challenge, particularly for institutions that don't have as many resources. I'm fortunate to work at a place that has, some world-class individuals and is very well resourced, that we can actually study how what we're doing and what's impacting what. But that is, usually going to be something that ideally we'd have some kind of randomization where we can see does the tool, if that's the intervention, that if you're randomized to getting the tool versus someone that's not, that we can actually measure that over time, that there's an improvement in outcomes.
Yeah, that's very interesting. For students who want the real patient impact and are curious about AI, how might they explore those paths?
Yeah. Well, I think there's any number of ways to do this, and we've certainly had a lot of students that have come through. I think probably one of the big things is, obviously connections help, right? If you're friends with someone that works in healthcare, that oftentimes helps, but it's certainly not a requirement. And in fact, like me, right, I didn't know anyone that worked in a hospital. I just asked to go volunteer there, and it worked out quite well. If you have a specific thing, certainly reaching out to someone about, kind of working with them, I think is a great way to kind of get started. There's any number of programs too that also kind of connect interested students with researchers, and usually people love to have, kind of particularly motivated people, right? I think that's a key, right? If you want to do this right, you've got to show motivation, you've got to bring the goods, but kind of jumping in, and kind of offering to help with whatever's needed. And it might not be and it probably will not be the high level stuff to start, but it gets your footprint in there. Show up to the lab meetings, show up to the, kind of the sessions, see what you can do to get involved with it and kind of build that footprint up. There's both, academic medical centers have opportunities for this, community medical centers have opportunities for this. Universities have opportunities for this. Even some nice high schools certainly can, kind of plug people into the right area. So I think that curiosity and reaching out and kind of seeing what's available, and not to get discouraged if someone's not available for you, right? Because I think that's one of the key things, right? Is you got to realize that everyone in medicine is busy, and just because someone doesn't respond to you doesn't mean they don't like you or don't think you're good enough for it. It might just be that they've also got 200 emails from the day, and they're caught up with any number of other things. So keeping that, that persistence, I think, can go a long way.
All right, now we're to the big question. Over the next 10 years, where do you think AI will change emergency care and why?
All right, so this is a tricky one, right? I think what we will probably see is, and again, we talked about kind of the magic word in emergency medicine is flow, is AI tools that are designed to really expand on what we're doing right now to optimize patient flow, as well as earlier diagnosis. So some very tangible things, like I mentioned, these ambient AI scribes are in their infancy. I also think there's probably a lot of former undergraduates in college that are now in medical school that are very sad because they were human scribes in the emergency department, and are now no longer able to do that with the ambient AI systems. But I think that's going to be a huge, huge component. I think we're probably going to start to see chatbots that are powered by large language models kind of being used to help triage people, even potentially before they show up to the emergency department, to kind of get an assessment of what's going on and to see if there's any early diagnostics, or hey, you don't need to show up to the emergency department based on what you're saying right now. You're perfect for an urgent care or seeing your regular, your family provider, and you can avoid the chaos of the emergency department. I think we'll also get much more rapid diagnostic tools that use AI applications, either in through kind of analyzing patterns in blood, or analyzing clinical data to help kind of guide treatments a little bit sooner. And I think what we'll probably see is the push for much more personalized care for some pretty complex syndromes that we don't have. We kind of use a one size fits all approach right now, using some AI tools to kind of help parse down and give very specific goals about what we're doing.
So, what I'm hearing is essentially anything that can improve organization and save time.
Yes, that is a huge thing in emergency medicine. Yes.
So, to close out, is there anything students interested in AI or emergency healthcare should hear that we haven't covered yet?
I think there's a lot that's going on right now in this field, right? Kind of, and if you're interested in it, I think at least recognizing that what was a hot topic today might not be a hot topic in 6 months, just with the trajectory that we're seeing. I think it's also, for people interested is to really try to jump in. And, there's a lot of tremendous articles that have been put out in the medical literature that really kind of help people bring them up to speed about how AI can be used in healthcare. And that interest, I think, becomes very, very, those papers help really kind of make things much more digestible, because one of the barriers to entry that I see, regardless of your level of training, is that a lot of times the words that people throw around become almost, well, if I don't know what that means, I can't really do it. And so kind of jumping in there. If you're interested in emergency medicine, right, asking to volunteer, I think is probably the easiest way, right? You'll really get a good sense, is the emergency department something that I'm interested in doing? And I think usually there's any number of programs that connect people with that, to give them a good opportunity to get a good sense. And I know at UCSD there's a wonderful program that brings in volunteers, sets them up with some research questions and stuff like that, and it's usually very, very well received. So I think that's probably what I'd say: is stay interested, accept the change, and again, don't get discouraged if you reach out to someone you really want to work with and they don't respond to you.
Dr. Wardi, thank you so much for helping me better understand how AI fits into real high stakes clinical care. And for the students listening, remember, the goal isn't to predict one perfect job. It's to build judgment, skills, and curiosity that grow as AI continues to evolve. If today's conversation sparked your interest, explore the other episodes in our AI in Healthcare mini-series. And to help you visualize how these careers are changing, check out our AI in Healthcare Future Jobs Map and the resources linked in the show notes. This has been Paths of Curiosity in an AI World, exploring tomorrow's careers through the lens of AI. Join us next time as we continue mapping the future, one field at a time. Until then, stay curious.